It's 9 o'clock, so we'll be kicking off very soon. There'll be no more jokes. Maybe I could just quickly introduce my co-host here. It's Dr. Loe Albaconi.
Hi everyone, good morning.
And Loe will be monitoring the Q&A function, and we'll be talking more with Loe soon. So it's 9 o'clock here. I think we will, it's 9:01 now. I think we'll kick off. So I'd like to start off by acknowledging the Kombumerri people. It's their ancestral lands that Bond University sits on. We're coming to you from Bond University today. And I want to acknowledge their deep connection with this land and pay respects to their ongoing custodianship of the lands and waters around here. This special event is being hosted by Wiser Healthcare. That's a national publicly funded research collaboration of 4 universities, Sydney University, Wollongong, Monash and Bond. But we are in growth mode, and very soon I think that national collaboration will grow much larger. We're funded largely by grants from the National Health and Medical Research Council, for which we're very grateful. Thanks so much for joining. This is a live event, but some of you will be joining later. So thanks for that. And there, if you want to join in the interactivity, please post your questions in the Q&A function, and a colleague will be monitoring that. Some colleagues are monitoring that, and we'll be feeding that back to the guests soon. So we're very excited today to bring you this event. We'll be talking soon with Dr. Ranjana Srivastava, who's a very high profile oncologist, also a columnist with The Guardian, and recently got yet another higher degree from Harvard. We'll be having a conversation with her soon. And also after that, a panel which will also feature Jan Donovan, one of Australia's leading health consumer activists and advocates. And Jan is a board member of the Consumers Health Forum. So we're very pleased to welcome Jan as well, and Ranjana. But first of all, let's talk with Rachelle Buchbinder and Ian Harris. Rachelle Buchbinder is a professor from Monash University. If you could join us now, Rachelle, and unmute, and same with you, Ian. And Ian Harris is an orthopaedic surgeon from the University of New South Wales. These two have global reputations for tackling this problem of too much medicine. And in fact, they've got together and produced a book called Hippocrasy that's just come out. Hippocrasy, How Doctors Are Betraying Their Oath. So thank you very much for joining us today, you guys. I think it'll be a fascinating conversation. So Rachelle, if I can go to you first and just get you to briefly define what this problem is, this problem of too much medicine, and perhaps how big it is.
So by some estimates, it's said that 30% of healthcare is wasted and another 10% is harmful. So this means that perhaps 60% of what doctors do is appropriate. And so Ian and I, as the more we practice medicine and we see patients, and the more we look at research and see research of others, the more we are alarmed that we think doctors are getting it wrong. And the problems really can be outlined as threefold, I guess. One is over-medicalization, so medicalizing problems that are not really medical problems. Over-diagnosis, so making diagnoses that don't benefit the patient. And over-treatment, so treating people unnecessarily. And this leads to waste of resources that would be better spent treating people that really need to be treated. And I guess the other thing is medicine as big business.
Thanks so much, Rachelle. And again, today we'll be talking about the problem, but we'll also be talking about solutions, and we'll get to solutions soon. But clearly this is a big problem. And I should say that both Ian and Rachelle are rigorously evidence-based. So while you're not seeing a lot of, you won't be seeing any PowerPoint slides today, trust that what we're hearing is evidence-informed analysis and opinion from two very senior people. Ian, anything to add to sort of Rachelle's introduction to the problem there?
No, I think Rachelle's encapsulated the problem very well. I think what's more interesting and what we get into in the book is how this came about. What's caused this problem? Why are doctors doing things that don't work? Because it just seems odd that they would do that. So getting to the root of it is interesting.
Well, Wiser Healthcare and many others have been trying to investigate exactly that question. What's driving this problem of over-treatment, over-medicalization, over-diagnosis? What are you thinking? And I mean, clearly there's many drivers, and the evidence suggests there are many: commercial, professional, public, cultural. But what's your view? What are the key ones, do you think?
Yeah, it's, as you said, it's very complex, and some people look at it a little bit too simplistically. Some people think, oh, it's just financial drivers, that are driving over treatment. And yes, there is some evidence that is contributing to part of it, but certainly that's not all of it. Some of it, people think, oh, well, it's our wish to want to be seen to be doing something. Doctors want to help, and when they're in doubt, they'll do something rather than do nothing. And that's probably part of it as well. I think that Rachelle and I probably agree that one of the major problems that's driving all of this is the lack of science in the the evaluation and the understanding. It's a lack of scientific understanding of the community, of the patients, but also of the doctors. So, most doctors, even though there are, say, financial drivers, most doctors aren't deliberately over-treating, knowing that it doesn't work for financial gain. Most of them think it works, they just don't understand the evidence, or there may not be evidence out there, and therefore they're just assuming it works.
Well, maybe at this point we need an example or two to make this real. I mean, a lot of people listening today know this problem well. We've got some very, very well-informed policymakers now, and the heads of professional societies and so on that know this problem. But for people who are joining who aren't familiar with it, can we make it real? Let's give an example or two just quickly to make this real.
I can probably give you an example, because since the book came out, there was an extract in the Australian Weekend magazine, and it included an example on shoulder arthroscopic surgery, which is one of the most common, I think the most common shoulder operation in the world. And I mentioned that it doesn't work, because all the evidence we have says that it doesn't work. And I got several emails from the shoulder surgeons about that. And I quickly found, they criticized one particular study because they don't like this study, and they've picked holes in it. But it became clear that they didn't really understand the evidence, and I think, it sounds harsh, but I think that's fair to say. I mean, there's been, 8 or 9 randomized trials on this topic, a couple of placebo trials on this topic. The only thing that is consistent is that all of these studies show that this procedure is not better than not doing it, or an alternative treatment. The evidence is pretty convincing, but the surgeons are just kind of like, well, we think it works.
This is
therefore
quite.
All the studies must be wrong. This
is quite extraordinary. What you're saying is that a lot of commonly performed shoulder surgery is no better than not doing the surgery. I mean, this is quite shocking, but this is what the evidence is showing, and this is not the only example, is it? I mean, we could talk about knee surgery or back surgery. Rachelle, an example from you.
Yeah, so a recent example for me is platelet-rich plasma injection. So this is a procedure that you draw the blood from the patient, and then you inject it back into painful areas like tennis elbow or heel pain. And it's been around for at least a decade. And all the studies, the high quality studies, if you pull them all together, also show that this treatment doesn't work. Yet a recent survey of Australian sports doctors found that 86% either use or refer for this treatment. So this is one that is commonly believed to work. It actually has no scientific basis. The actual clinic, the preclinical studies were actually bypassed. They were never done. And it was just accepted into usual care, despite us knowing for many years that we shouldn't be introducing things before they've been properly evaluated. So that's a recent treatment that was introduced compared to shoulder surgery that's, decades old.
Yeah, I mean, the big caveat here, and I'm sure you would both agree, is that vast amounts of what doctors do is incredibly valuable. It reduces suffering, it can extend lives. I mean, there's no question about that, no argument about that. Tests and treatments, vaccinations, pills, surgeries, procedures, these are all incredibly valuable parts of healthcare. And in addition, we have in Australia, we're quite blessed, I think, with this national universal health insurance system called Medicare, largely publicly funded, that tries to maximize access and affordability. I think that's an important caveat to add here. But Ian, what would you like? Yeah. I can see you wanting to respond.
Yeah. Yes, you're right. So we have this system in Australia where, when drugs want to get introduced or new procedures want to be listed for reimbursement, and they have to go through quite a rigorous process where they have to be, shown to be effective in scientific studies. And I think that's a fantastic system. So, at the moment in my field of orthopaedic surgery, there's a couple of procedures that are jostling to be listed, because once you're listed, not only does Medicare fund it, that means the private healthcare funds fund it, the private hospitals will do it, and it becomes widespread. So it's a great system. The problem with the system is that system only came about, that whole list of things that are in the MBS only came out in the mid-80s. And most of the procedures that are in it just automatically got put in it when it started. And they have not been subjected to these rigorous tests. So it's a little bit of a double standard. Whereas if I have a new procedure, I have to go through, these rigorous tests to show that it works before it gets listed. And yet all the procedures like this shoulder operations, knee operations, and things that we've talked about were already listed, and nobody's looking at whether they work or not, or whether they should be delisted. So there's a fault in the system we have, even though, as you say, theoretically it's great. And a lot of what we do is good and does have good evidence.
Rachelle, I mean, you've done a lot, and we won't go into in great detail, but there's another great example called vertebroplasty, which is a injection into the spine to help intense pain and so on. You've also looked at that. That's another example, isn't it?
That's another example where there are 5 placebo-controlled trials now, and they all show the same thing, that there's very little, if any, benefit in terms of pain or function. And one of the things that concerns me about ongoing use of this treatment is that not only is it no better than placebo, but there's lots of potential for harm. And I've seen people who've had been paralysed. There are case reports of the cement going into the heart and perforating the heart. You can die of cement going into the lungs and causing pulmonary embolism and death. So there are lots of potential harms, and patients are still receiving this treatment, and they're not being advised about the potential for harm. They're not being advised about what the evidence says either. And I think that's a real concern that we also have.
You're both in the sort of musculoskeletal area. You as a rheumatologist, Ian as an orthopaedic surgeon. So a lot of your examples obviously come from your clinical work and your clinical reality. But as we all know, the evidence here goes across the spectrum in terms of medications, lots of evidence, things like commonly used PPIs for stomach problems, grossly overused. Things in terms of the pathology area, lots of testing, commonly used tests that GPs and others order, grossly overused. I mean, do you want to talk a bit about other examples beyond your field, just briefly?
Yeah, I'll jump in. We do cover a lot of other examples. We had to be very careful and look at the evidence very well, and we even ran it by specialists in those fields. But other things that are very common and well recognised as being overused, cardiac stenting, for example. And it's a good example, I think, because it shows the doctor's thinking when they do an angiogram to look for blockages in the heart. If you see a narrowing or a blockage, it's very tempting to want to put a stent in to open up that blockage. But the evidence is that if the patient has stable angina and isn't actually having a heart attack at that time, that they're probably just as well off not being treated with a stent and being treated with medical therapy. But just the temptation to treat is so great, I think, when you're there. And our bias always falls on the side of over-treating and intervening where there's doubt. And I think that leads to a lot of over-treatment, is the doubt or uncertainty.
That something might help.
Yeah, and even to the point where when there's very little evidence that it helps, even with major operations, and I talk about this, about the hero surgeon, you know, doing sort of massive operations that have very little evidence and high chance of harming the patient. But it's kind of like, well, we won't know until we try, and you might be the one, you know, that will benefit. And how many people are harmed for every one person that's benefited for that kind of thinking?
Rachelle, another example from you?
So I guess I'll give you a different example, and that's pathology tests. So we know that a lot of pathology tests are ordered unnecessarily. And if you think back to medical school, we were taught that when deciding about whether you're going to do a test or not, it's important to know why you're doing the test. Firstly, what are you looking for? And what's the pre-test probability? What, you know, is this test going to change that? Are you 90% certain? Then the test may not be necessary. If you're 10% certain, will it change you to make it a higher proportion? But many people are subject to tests for which there's no really good reason. And they often have batteries of tests. They often have weird combinations of tests. And that, you know, if you think that by probability, 1 in 10 tests will be abnormal by chance, then if a patient has 10 tests, 1 of them will be abnormal, and that will send you down a rabbit hole towards overdiagnosis and overtreatment. And I think that doctors need to start thinking about the need to not do something, to think about what's the value proposition about doing tests versus waiting, versus advice and explanation that you don't need the test. And there are lots of tests as well in our field, particularly imaging, that get done without thought prior to what are they going to do as a result of the change. And a lot of the time you see age-related changes that are normal, but people jump on them and think they need treatment.
I think I'm right in saying that among those pathology tests you mentioned, a couple of examples are iron tests. I think in Australia there's an epidemic of unnecessary testing of people's iron levels, not to mention that those tests that are valuable. Thyroid function tests, I also understand there's been a huge explosion there. Many of them may not be necessary. So these are very commonly used tests.
Vitamin D is another one.
Vitamin D. So let's talk about what we can do. You know, we've got a few minutes before we wind up this part of the event this morning. What can we do? I mean, just tell me first about how hard it is or easy it is to talk to your patients in the clinic about this, the people you see. Ian, I presume you spend a bit of time trying to talk people out of surgery, but tell me how hard or challenging that is.
Yeah, that's interesting because it's often raised by my colleagues as being difficult. You know, they'll say, oh, the patient wants to have a knee arthroscopy, or their GP has told them they need it, or they've come in demanding it. I see a lot of patients with knee complaints who come in, you know, expecting to have surgery. I have no problem at all convincing them or explaining to them that it's not necessary. So I actually don't think it's difficult. And when I say to them, oh no, I don't think you need an arthroscopy because the evidence is that you'll be no better off than if you don't have the arthroscopy. It won't change your underlying condition. You know, you'll still be okay. And it's a lot of people are relieved. Oh, well, that's good because I didn't want to waste time or money having an operation. So it's not, I don't think it's very difficult to talk people out of procedures. Tests, I think, is difficult because most people can't see how getting a test can be bad. It's more information than we have now, so therefore it must be good. And it's difficult explaining that to doctors as well. And so why not just get an MRI scan of my back, and then if there's nothing there, I'll be happy. The problem is with every MRI scan of the back, there's something there. And then it becomes complicated.
Rachelle, what about you? What's your experience of trying to talk to people about this?
Yes, so my experience is that I often see people after they've received multiple tests that they didn't need. They've seen different specialists. They've had different treatments that we know are non-evidence-based. And so my job then is to try and unpick all that and undo all the harm. And I, like Ian, don't find it difficult. I explain it. I explain exactly what Ian's just said, really. And you know, most people feel really reassured by that, and they go, oh, so I don't need to do anything. You're telling me it will actually get better if I do nothing. And I'm going, that's exactly what I'm telling you. And they have the opportunity to come back or to call me if they're worried. But I've tried just to allay that anxiety and display the evidence that actually no treatment will change what's going to happen to you for this condition. It's just going to get better in its own time. And I can't tell you when that will be, but it will get better.
Thank you. We are almost out of time now, but we haven't talked much about the sort of big picture solutions, but we will have a half-hour panel conversation, and we will definitely come back to that. So please, if you've got ideas, either of you, for sort of systemic reform or whatever else it is, please share it in the panel discussion. Just before we throw to see if there's any questions for you, two brief questions before we move to Ranjana. I think I'm right in saying that you two started hatching the plan for this book, Hippocrasy, when you were meeting at a Preventing Overdiagnosis conference. Is that right?
Correct.
It is. And so Preventing Overdiagnosis, for people who don't know, is something that Wiser Healthcare initiated about 10 years ago. It's a series of international conferences to discuss these issues, both the problem and the solutions. And there's a series of online Preventing Overdiagnosis events underway at the moment. But hopefully the next big meeting will be in Calgary next year, hosted by the University of Calgary and the Canadians. And that should be a fun event in the middle of next year. The last time we all got together for Preventing Overdiagnosis was in Sydney, hosted by Wiser Healthcare at the end of 2019. But just before we move to our next guest, I'm just going to talk with my colleague, Dr. Loe Albaconi, and just see, he and colleagues have been monitoring the Q&A. Is there anything, just briefly, a couple of questions before we go to Ranjana?
Yeah, we have a few questions and a few comments, few questions related to the driver of overuse, overdiagnosis, asking about the training, whether that training location where they have been trained associated with the practice, and also how we can manage train the clinician to say no to the patient if they ask for more overuse and over testing. And also a question about the psychological factor and how to manage and to more investigate the psychological factor for overuse and overdiagnosis.
Thank you, Loe. You guys probably heard that. Any quick responses there? We've got the sort of psychological factors here and how to deal with them. There's a whole science around that Wiser Healthcare has been advancing, and also the training issue. How could we possibly reform training and help doctors say no?
So I think, science literacy, clinical epidemiology is just the basis of clinical medicine. And I think that every clinician should actively understand clinical epidemiology. Perhaps it's not taught as well as it could be in medical school, or it's not, or students can't directly see the applicability, but I think that this is something that clinicians fundamentally need and need throughout their career. So I would vote for compulsory critical appraisal skills for all clinicians as a start.
Thank you. Ian?
Yeah, I agree. I don't think there's enough science training in medicine. It's too much of an apprenticeship where we kind of learn by experience and seeing what other people do. And I don't think that's appropriate for a scientific endeavour.
And just quickly, this psychological aspect, any quick comments on that?
So as Ian said before, we know that patients don't get the segue between tests and over treatment. I think that it's a cultural issue, some of it, that we want more, that it's very, we want more things in our life. The more we have, the happier we'll be. So I think some of it is cultural. I think we can address some of this by empathy. And we talk in the book about training. You can train people to be empathetic. So I think that these are skills that are also fundamental to doctors and other health professionals.
Look, thank you both. We will say goodbye to you briefly, both Rachelle and Ian, and we'll see you on the panel very soon. But now we're going to talk with Dr. Ranjana Srivastava. So Ranjana, if you'd like to join us now, hello. Thanks so much for making the time. Ranjana is a cancer specialist. She works in hospitals in Melbourne. She's a columnist with The Guardian, and she recently added to her CV another higher degree from Harvard very recently, and that's just a few of her hats. So we're very delighted to have you, Ranjana, today. You've heard what Ian and Rachelle have been saying. Can you respond to it? As a working doctor, how real is this problem for you in your daily life?
Oh, I think it's very real. And good morning to all of those who are listening and people who will be joining us later. It is something that I think every practicing doctor, and in fact, anybody who is a consumer of healthcare should be vexed about. The problem of overdiagnosis, the problem of over investigating is rife. And as we have heard, it's not simply a matter of economics. It actually does real harm to patients.
Is this something that you see? I mean, you're a cancer specialist. When people think about cancer, they think about a deadly disease. I mean, yes, we have therapies that can extend life now and reduce the suffering of people with cancer. But is this an area where you see this problem existing?
Well, I would have to concede uncomfortably that cancer medicine is an area that is rife with over-investigation, duplication of investigation, and the harm done to patients. And, I would say that it's almost always done with good intention. But I think we're hearing that that's not enough. And, we've talked about some of the financial incentives potentially that people may have to over-investigate or to deliver more services. But that doesn't even come into play in the public hospital system. And one of the frustrations that I have about the public hospital system is no one actually ever talks about money. The patient doesn't get a bill. The doctor has no idea about the cost of investigations that he or she has ordered. And so in the end, I think that is where we all become less accountable because, sitting beside me in clinic today is a pile of different order slips. And if the patient never says to me, why did you order this? Because it cost me money. And no one ever says to me, by the way, this is the bill emanating just even for your interest. In clinic today, you ordered $20,000 worth of investigations, just letting you know. Would be really interesting, but it doesn't happen. And I think, you know, one of the frustrations that many cancer patients will know quite intimately is this issue of fragmentation of medicine, which means that the same test is repeated by different doctors. And that's just appalling. I saw a patient a few weeks ago who had a CT scan a week ago by the GP, followed by a week later because he came into hospital, and then a third scan that had been ordered as a regular review by his oncologist. Now, really, he just needed one of those scans, but if those people were talking to each other or looking out, and also if the patient were able to inform these various doctors, we could have saved a lot of money and potentially the harm that emanates from doing 3 CTs where one will suffice.
I mean, I think Rachelle raised this point too about that often people can't see that the harm or the danger in just having a simple test, whether it's a simple blood test or even a CT scan. But I think one of your columns earlier this year in The Guardian was about a tragic example where someone had some simple tests but had catastrophic results. And I think that person was being screened. It was a healthy person being screened for a whole lot of things, but with quite catastrophic results. I'm not sure if you remember the details, Ranjana, but that was a very powerful and tragic example that ended up in a coroner's inquest.
Well, I've written about so many of these cases, and you know, the more you practice, the more you see evidence of this. But I think that the case you may be referring to is the case of an elderly woman. So I also practice general medicine apart from oncology, and we have a lot of elderly patients on the ward, on the general medicine ward. And one night, someone sustained a fall, and this patient was examined by the resident. The patient seemed to be okay, neurologically sound, but as part of sort of a protocol of patients who fall, many of them undergo a CT scan of the head. And I think in this instance, actually, it was a CT scan of the hip to ensure that she had not broken her hip, although there wasn't any clinical evidence that she had done so. So she went downstairs for a CT scan, and she was quite agitated because she was elderly and she was also cognitively impaired. And so in order to accomplish the CT scan, she was sedated. And it was supposedly a mild dose of sedation, short-lived sedation, just enough to carry her through the CT scan. Unfortunately, and as you know, as often happens in the elderly who are cognitively impaired, that small amount of sedation actually triggered a process of delirium. This patient, unfortunately, spent so long in hospital, developed a lot of complications, ultimately died. And the tragedy there were many tragedies, but what I felt sort of really sad about is that the CT scan of the hip that had been done, no one had even looked at it. I was the first person to click on it after she had died. It was normal. I didn't even know that it had been, or you know, at some point I clicked on it, it was normal, but the consequences of getting that normal CT resulted in a death. And unfortunately, I think clinical practice that is hasty and that is pressured is often reliant on ruling in and out things via blood tests and scans rather than spending more time at the bedside actually using our eyes and our ears.
You've talked about sort of end of life. You obviously see people close to the end of life. Do you think that end of life period is a place where there is a lot of unnecessary intervention, or a little? How do you see it? I mean, I think you've also written in your most recent book, A Better Death, about optimizing the ways in which we die, if you will. But how much is this problem of too much medicine related to trying to achieve the best death we can?
Well, evidence from around the world shows that the major expense, the healthcare expense, is actually in the final year of someone's life. And we certainly see this in end of life, not just in cancer, but everywhere else. And I think, you know, again, Sometimes it is driven by good intentions, saying, well, what else can we do? How will this test, how can it hurt? I think, how can another blood test hurt? There is also just a lot of general sort of neglect to stop and think. And as Rachelle was saying before, you do a test that alters management. But we don't think about that very often in medicine. You sort of order the test and then you think about what to do with it. A good example of end-of-life care that really hurts patients, end-of-life lack of care, is the habit of doing regular blood tests. And at the end of life, many people don't have good venous access. They have thin skin, and they will be punctured 3 or 4 times to get a blood test really that is not going to do anything to alter their prognosis, and in fact makes them uncomfortable. But the routine and the default has become these tests, and it takes somebody to step in to say, no, we are not doing them anymore. And in the era of fragmented medicine, one of the other things that's become quite sorry is that the average patient is often managed by half a dozen doctors. They're organ-specific doctors. You have a kidney doctor and a heart doctor and an infection doctor and a cancer doctor. And so sometimes stopping doing investigations relies on all these doctors talking to each other and agreeing in the best interest of the patient. And when you talk about it like this, it really shouldn't be so hard. The best interest of the patient should be front and center for all of us. But unfortunately, it's not so easy. And I think patients suffer as a result of that too.
So this issue of communicating, not just to patients, but to other doctors about this problem, it's sort of, in one way, it's hard to understand why it is so hard to communicate about this problem, given how common it is. But I think there is still a sense that it's counterintuitive for many people to hear that perhaps not getting the test will be better for their health, or not getting the shoulder surgery might be better for their health. And so how do you think about this problem of communication? Is it something that you try and communicate with your colleagues about or your patients about? Tell us about that.
Well, I've tried to make it a pillar of my career to write about this, to teach my residents and my fellows about this. I think for far too long, there's been sort of a nobility about doctors saying, I'm doing the best for my patient. And I think it is a statement that can be very difficult to argue with because you sound churlish if you do so. But I think we do have to step back and examine and be self-aware and examine ourselves as to how many of the tests and how many of the interventions that we offer our patients are potentially and our own feelings of helplessness. And I think in my field, this comes down to, it is so much easier to order another scan than to talk to a patient about their mortality and leave that talk to another day or to another person. So I think that modern medicine needs to change some of its paradigms. We are living far longer than we ever have. Problems people are now getting, people don't die in their sleep most of the time. They have a stepwise decline from chronic diseases. And so sort of having a conversation like we are having today, but with also our patients and the general public about what to expect, what can be fixed and what can't be fixed, emphasizing the value of prevention rather than relying on a cure. All these things are so important. And I think that medical education needs to change with the times as well. And I'll say finally that all through I cannot recall a conversation about cost or about harm that wasn't, sort of a broad statement about first do no harm, sort of a statement. But what does that mean at the bedside? What does that mean ordering a blood test every single day for a patient who is dying? I think we need to bring those things more front and center, and we need role models in medicine who are willing to do that.
So Ian Harris and Rachelle Buchbinder, they both talked about the need to reform medical education. You're saying the same thing. This is clearly part of the agenda, and indeed WISER and colleagues within WISER have been working on this, and there's others around the world too, working to bring these ideas into medical curricula, and not just medical curricula, but the nursing, allied health professionals and so on. But let's just imagine, let's have a thought experiment here, Ranjana. Let's imagine that you're the health minister, the federal health minister, which I understand is not outside the bounds of possibility, given some of your aspirations. So let's say that you're the health minister. You're aware of this problem. Okay, you're being lobbied by a lot of other people about a lot of other issues. But on this particular issue, what do you start to do to the health system to try and wind back this problem of medical excess?
All right, that's a huge question, but let me try to tackle that.
I'm sure you can.
I do think that medicine needs more accountability. It's not something we want to hear. People will often say, you know, what can I do? I'm just one person in the system. But my response to that is, as clinicians, we are the system. And if we are not the gatekeepers of it, it will never happen. So I do think that at various levels, whether it be what procedures are listed on the MBS, but at a more granular level, the things we do to our patients, the way we speak to our patients, I think that some accountability is a good thing. Oops, my clinic light has gone off. Just bear with me one sec, and there we go. It's back up. It's a motion sensor.
That was maybe that was Greg Hunt maybe organised that. He didn't want someone else stepping into his shoes. But go ahead, please.
I think the other thing is about medical education, and you know, there are certainly great reformers and good thinkers in the Australian medical system. But you know, I will admit that it's very difficult to change a curriculum, but change we must. And I think, you know, it's very important for students and young doctors to learn about anatomy and physiology. But is not the medicine that doctors are practicing. And so we need to have a better connect with modern issues, you know, issues of ethics and dilemmas in medicine, and communication, which has always been an optional extra in medicine. Palliative care, you would be lucky to get a week or two of palliative care teaching as a medical student or as a junior doctor. But those things have become increasingly important in the last 10 or 20 years. So we do need to shift the system.
I mean, I think I'm right in saying that part of what has framed your view has not just been the clinical reality in the Melbourne hospitals or the Harvard degree, but it's also been your background and perhaps coming from a place where a lower resource setting, where the waste of resources is a much more harmful outcome than it is in a place where there is apparently plenty. Do you want to talk to that at all?
Yeah. Thank you for asking that. I do think that, you know, you gain perspective from traveling, from working, and from opening your eyes to various medical systems. In the interest of time, but this is a very good story for anybody who is a clinician and otherwise, so I will share it. So I grew up in India, which is, and in particular, a state which is impoverished. And I went back there to do my elective. And I worked there with a surgeon who had trained in the UK and was not only a surgeon, but also a physician, a social worker, the resident psychologist, and all in one. And he saw patients. He was a urological surgeon who saw everybody who walked off the streets, which was quite amazing. So one day there was this older man who walked in with terrible abdominal pain, and he had been brought in on a cart, on like a bullock cart, to the clinic. And the surgeon got him off, people got him off the cart and put him on the bed, and the surgeon examined him. And he percussed his abdomen. And percussion is essentially a clinical technique where you are looking for certain signs in the abdomen. And the surgeon said to me, the observer, he said, this man's abdomen is hollow. He has perforated a viscus, he has burst something in the abdomen, and we will need to take him to surgery. And I'm sitting there, I was a medical student in Melbourne at the time, having come from my first world bubble. And I said to him, well, what about the bloods, the CT scan, you know, the other things you need to do before you take a man to surgery? And he looked at me and he said, well, if I sent him for a CT scan, because this was just a clinic, if I sent him for a CT scan back by bullock cart, he is so unwell that he would die in the process. We don't have the means to do a blood test right now and wait for those results. We're going to take him to surgery. Took him to surgery and indeed opened him up, and he had a perforated gastric ulcer. He was stitched up, he was sewn up. The man walked out of that surgical setup after 5 or 6 days of being in hospital. And I've never forgotten that, because I was absolutely stunned at, you know, sort of the clinical medicine that was being practiced there, because this surgeon was forced to do so. But this is the joy of clinical medicine. This is the gratification of being a clinician. And one of the things we are losing, and we will often joke in the oncology clinic, you don't need your stethoscope because there's the CT scan that will tell you what the lungs sound like. And, you know, we don't examine people anymore. We don't lay hands people on anymore. And that's not good medicine. It's not good empathy. It's not good communication. And I think when you look around the world, and I've worked in other places where really you have your medical training, you have a stethoscope, you have a blood pressure monitor, and very little else, you learn to rely on those tools. And they're actually really good tools for the vast majority of patients.
Thank you, Ranjana. We're going to bring in the consumer voice soon in the form of Jan Donovan. But before that, we might just see if there's any a question or two from the audience. We'll just throw to Loa here again. Any questions for Ranjana?
We have a good response to questions, some comments and a few questions. So maybe we'll start with David Henry question about there's a huge advancement in the life expectancy across the 30 years. How you could explain that with the huge, if there's a huge overdiagnosis, overuse?
That's a great. This is a question from our colleague David Henry, and again, I think he's also wanting to stress the great advances that have happened in terms of both medical therapies, but also preventive therapies and so on. And clearly, diagnostic tests and diagnoses are central to that. So, you know, how can we explain this great lengthening of our lives and indeed quality of our lives if at the same time we've got this massive problem of too much medicine? How do we explain that seeming contradiction, Ranjana?
Yeah. Oh, I think there have absolutely been some great advances in medicine. And off the top of my head, you know, the advent of antibiotics, cutting down the rates of heart disease, having effective chemotherapy for a lot of cancers. I mean, cancer survival rates are going up and up. Those are good things. But I think in between those are many more instances of over-intervention, of over-diagnosis. In the realm of cancer, for example, let's just take the prostate-specific antigen, the PSA test. Now, I run a geriatric oncology clinic, which is devoted to elderly patients with cancer. My oldest patients in that are sometimes 100 years old. It is very painful for me as a clinician to see a 98-year-old man who has had a PSA test done, which is high, because the man has dementia and lives in a nursing home. He's not going to die from prostate cancer. He is going to die with prostate cancer. And so to subject this man to a blood test and to investigations and then put him through the inconvenience of coming to a public hospital clinic to wait for a couple of hours sometimes to be checked in, especially in the era of the pandemic, and to see me only to be told, actually, we don't need to do anything about this. And in the first instance, you know, I think you shouldn't have had the test. So I think there are many other such examples of wasteful testing. And, you know, by no means should we stop doing what helps patients, but we can't put everything in the basket and offer all tests to all patients. The PSA is a great test for the right person, but not for the patient that I saw, for instance.
Thank you, Ranjana. anything else just quickly before we move on?
Yeah, maybe about the patient. There are a few questions about the patient and how to deal with the patient as a reason driver for the overdiagnosis, overuse, or also the solution. All
right. Well, maybe we'll throw. That's a good point to throw to Jane Donovan, and then we'll come back to more questions during the panel discussion. Yep. Thank you, Louise. All right. Thank you very much, Ranjana, and we'll see you very soon, just in a few minutes for the panel discussion. But now we'll just throw to Jan Donovan. Jan, thank you so much for joining us today. And Jan Donovan is, as I said, a board member of the Consumers Health Forum, which is the major peak body for consumer health organisations in Australia. And Jan has been working with the Wiser Healthcare research collaboration off and on now for quite a few years, so has a sense of this problem. But Jan, I don't know whether you want to start off by just responding to what you heard or giving a sense of how important this issue is from a consumer perspective. I mean, let me ask you first, from your perspective, I mean, you're a consumer of healthcare like all of us. You have loved ones who interact with the system all the time, you know, but you're also aware of some of this evidence now too. What's your view on this problem of too much medicine?
Thanks, Ray. And can I just congratulate the authors on the book? I've read the book and highly recommend it. And thank Ranjana. She said some very important things. Yeah, look, it's a very important issue for consumers, not least because they carry the costs of a lot of the medical interventions that may be being done unnecessarily, but they also expose themselves to adverse events and the risks and harms that both Rachelle and Ian talked about. So I think for consumers, it's knowing what is the right approach when they do get sick and they do need to be treated. And that's where I think health professionals have a very important role. I think it was Rachelle who talked about, but certainly in the book, about decision-making, shared decision-making. Many consumers want the conversation. They don't want to be told what's wrong and what the treatment is. They want a conversation about what's wrong and what the possible treatments might be, including watching and waiting. They need to, many of us want to talk with health professionals who understand us. That is, and Rachelle talked a little bit about culture. You know, a quarter of the Australian population were born overseas or have parents born overseas, many of whom aren't proficient in English. So going to the doctor is a challenge for many, particularly the older population from those culturally and linguistically diverse communities. So health professionals are reluctant to engage interpreters and reluctant. We don't have easily accessible information in community languages, but it's more than that as well. A lot of people have trouble understanding the information and acting on the information because it's not designed for them. So we need to think about how we approach conversations, communication, which Ranjana talked about within the health system. It's more than just the doctors learning communication skills in their medical education. It's bigger than that now because so many of our community are not able to read the screeds of information and understand it and act on it. So that's a key area.
So you're talking about this notion of shared decision making, of producing evidence-based or evidence-informed information in a range of formats, culturally appropriate, that can help inform conversations and decision-making on the part of consumers when they're thinking about whether to have that test or treatment.
That's exactly what I'm saying. As well, you know, the choosing wisely questions, which Rachelle also talks about and Ian talk about in the book, they're not widely publicised. They're not, and there's very little support for consumers to ask those questions. You know, they're good questions, and particularly the first question in regard to what is the evidence for this treatment, and they're really good questions, but you can't just publish questions and expect consumers, people like myself will ask them, but you know, my older relatives wouldn't ask them.
Yeah, and just to clarify for people who aren't familiar with Choosing Wisely, I mean, most of the people listening probably will be. It's a big international campaign now, started in the US but run all over the world, promoting a more skeptical approach, I suppose, evidence-informed skepticism, and promoting the idea of asking more questions of your doctor. How well does this work? What are the harms? What are the alternatives? What happens if I do nothing? That kind of thing. I should say, Jan, it's so good to have you here on this conversation, because I'm aware that we've got a very quite strong medical bias today in the panel. You know, we've got three very senior specialist medicos, notwithstanding the fact that they all have amazing reputations, but it does lend a certain medical bias, if you will, and so that's why it's important to acknowledge the role of psychology, the role of culture, and all of the other, the role of inequity here, all of these other factors, not to mention all the social determinants of health that come into play as well. But I think these are things that the contemporary consumer movement is very well aware of and has become a quite powerful voice in this conversation. Would you agree?
Yes, we take a keen interest in these issues because the health of the community is our primary focus. I think I just want to elaborate a bit on communication, and I think we've seen it's extremely important, you know, and I think we've seen in COVID-19 the public health messaging. You know, I think Ranjana said it. We don't put enough emphasis on preventing illness and harm. You know, we've seen through the COVID-19 messaging and now the daily publication of vaccination rates, certainly where I live, has made a huge difference to people's views about vaccination and why it's so important. The public health messaging around COVID, the prevention and preventing COVID, simple things like washing your hands, social distancing, you know, getting tested if you've got symptoms. This is where testing has been good. They're the sorts of things that in the future in Australia, I would like to see much more emphasis on preventing illness through public health. And you know, again, in the book, Ian and Rachelle talk about some of the big health issues we're addressing, which are also include, you know, the social factors such as alcohol consumption, things like diabetes. There's a lot we can do ourselves, and that's where information and knowledge is power for consumers. If we know what we can do to help ourselves, then that gives us some agency, some control. And that psychologically is very important. So much more emphasis on prevention in the future. And I think all of the speakers have said that, and certainly it's a key point in the book.
Thank you, Jan. I'm going to bring the other panelists back now. If we could have Ranjana, Rachelle, and Ian join us for the final half hour of this event this morning. We're going to have, we'll have a quick discussion among ourselves now, but then we will bring in some more questions from the audience into the discussion. Jan, you've mentioned the pandemic, and it almost seems strange to be talking about the problem of too much medicine in the middle of a pandemic, where medicine, tests, treatments, vaccinations are playing a primary role in fighting this alongside all of the public health measures and so on. I mean, does anyone else want to respond to this notion of whether this is the right time to be talking about too much medicine?
It's always a good time. And the pandemic's been around for a long time. It's probably going to be around for a long time. And we're not saying that we shouldn't be doing medicine that works. A lot of people tend to misconstrue the message as being, oh, medicine is bad. And what we're saying is large chunks of it are bad. But large chunks of it are good, you know, and so vaccination, for instance. So we need to make that clear, that we're not saying that we shouldn't be doing effective things. We should be doing more of them. I think any time is a good time to point out that there needs to be more science in medicine, and probably even more important now when a lot of stuff that's going around is bad science and misinformation about COVID.
Rachelle, Ranjana?
No, I agree with Ian, and I think that in the coming days, when the pandemic is behind us, and many people have not had the care that they needed, we really will have to try and make sure that we put the resources to people that really need our care, because otherwise we're really wasting, you know, we're going to harm people more by this waste. And I think one of the other things that I wanted to say that didn't come out is I think that we also need to improve the science literacy of the general public. And I think in schools is a perfect example of where we could talk about evidence-based medicine. I'm sure that could be brought into the health curriculum. And I think if we improve the literacy, the health literacy of the public at the same time as we improve the health literacy of health professionals and the science literacy, then that will amplify the message as well. And then as one other thing to David Henry, that if you look through history, that the many advances have been due to public health measures. In fact, they've been due to clean water, housing, getting rid of smoking. Those sorts of things have been huge in improving the health of the population. So I think that medicine has had incredible advances, but most of our improvement in longevity has been due to public health.
You mentioned there, Rachelle, the idea of sort of teaching the principles of an evidence-based approach in schools. And indeed, I think I'm right in saying that the already some work based out of Norway has been doing this in a very big and systematic way. The Informed Health Choices group that is associated with Andy Oxman and others. And they, I think, have shown in a very rigorous randomized controlled trial run with Ugandan school children that you can, in fact, increase the critical skills of school children vis-a-vis medicine and healthcare. So I think the evidence is there that you can do that. Jan, what do you think of this idea of teaching kids in Australian schools to be more well-informed about their medical choices?
Well, actually, this question's come up a few times recently, and I obviously think, I'm a former teacher. I obviously think there's room in the health curriculum, but also in the science curriculum. But I think I agree with Raquel. We need to educate our younger population about evidence and what is good evidence and what isn't. And I think that would help them also decipher information on the internet because, you know, that's where they're accessing a lot of information. And so they need the critical appraisal skills that Raquel is talking about for medical schools, I think, a bit earlier. And I think there are a lot of schools that are doing this, but the science curriculum, I think, is the ideal curriculum. Hopefully we'll see more young people choosing science in the future. And we need to teach those critical appraisal skills early, because kids are up to it. Let me tell you, they're up to it.
Ranjana, any comments on the teaching of kids or the context for this discussion, i.e. the pandemic? Any comments on that before we go to the audience?
Being the last speaker, I have the fortunate position of having nothing else to add to all those comments, which were spot on.
Well, great. Well, let's just we'll take another question from the Q&A chat. Loie, anything to?
So maybe the comment of the patient as the driver and the solution for the problem of over-diagnosis, overuse. And there's a specific question about the choosing wisely 5 question. And the problem, Robin Lender, and the problem that commonly the feedback that there's no permission to ask this question, and how to create this permissible environment for the patient to ask these questions.
That's a great question. This is from Robin from Choosing Wisely.
Yeah.
Thank you, Robin. So this is a great question. So how do we, from Robin, from the Choosing Wisely organisation in Australia, how do we create that sense of permissibility within the healthcare system and the clinical encounter to encourage, to empower people to ask these questions? Jan, you first.
Thanks, Ray. Thanks, Robin, for that question. Yeah, look, I think there is more we can be doing to support people. And this is where communication skills in medical school play a key role. You know, it's a shame we do have to train people to communicate, but we do. And there is a skill. And I think if young doctors can learn to that empathy, that warmth, so that people feel they can open up and ask questions that are worrying them, even if, you know, it's as simple as what's worrying you about what I'm telling you. You know, you must, is there anything you want to ask me? You know, it's not rocket science, but in the busyness of the medical practices now, that warmth and empathy often gets lost to the procedure, the test or whatever is happening. So, you know, we need a cultural change more broadly where, you know, the older doctors will do it. I've got a great GP. He'll sit down and talk to me and my, and I've got also a woman GP. We have a really frank conversation. So, you know, it's finding people that and encouraging young doctors to really let their patients open up.
Ranjana, a quick comment?
Yes, Ray. I think that it's great to teach doctors to communicate. But I think that the Choosing Wisely questions are so powerful that a low-cost initiative would be to display them in every clinic, in every medical practice, so that the patients who are waiting to see doctors read them and know that they have the implicit permission to ask those questions. One of my fears about the reservations about getting doctors to do most of these things is the age-old plea of doctors being too busy to think about too many things. But I think that every room should have the Choosing Wisely questions displayed, which will both nudge the doctor, but importantly, nudge the patient. And you know, this is one of the reasons that I write, because I think that sometimes instead of preaching more to doctors, we need to come and empower consumers to drive change in medicine.
Thank you, Ranjana. Rachelle, I think I'm right in saying that was one of your motivations to write this book and put yourself through the horror of writing a book, was to get to the public. I mean, talk to that.
Yeah, no, exactly. I mean, some of my early research has been shifting societal beliefs about back pain through mass media, showing how powerful it is. And I think that the powerful thing is that you train everybody at the same time, and that shifts the average. And with the average are the reluctant people, they come along as well. So I think that cultural shift is spot on. And I think, Ranjani, that's a great idea. I'm going to do that straight today. I don't have those signs up, but I think they're really useful to have up, actually, and more to remind me to make sure that I leave that room for patients.
Thank you, Rachelle. Ian, any comment on this question from Robin Lindner about creating a more permissible, space so people feel empowered and able to ask questions of professionals they're often intimidated by?
Yeah, I agree with everyone that it's something we should do. The feeling amongst patients that I talk to is that they think that, for example, seeking a second opinion is a bad thing. It's an insult to the doctor when it's not. Most doctors don't mind if you get a second opinion. It's not a problem at all. But so there is an education that needs to be done. And I think until recently, I've been very much in favour of solely looking at, educating doctors, educating the public, trying to bring this up on a constructive way. But more recently, I think that we need more, and I think that we need actually some, top-down controls, financial levers, and things like that. I've always avoided that because I think it's a punitive way of getting change. But I think that time has told us that carrots aren't enough, and we sometimes need some sticks to create change as well.
Well, before we get to the sticks and the big sticks and everything else, I mean, just to put an underline under here, I think we're all agreed on the need for this sort of, let's say, cultural transformation that permisses and encourages and empowers people to be much more questioning. And I think that comes with the change in attitudes, but it also needs resources, let's be frank. And so that kind of campaign, that kind of strategy across a whole lot of domains, from mass media to universities, would need resourcing. But let's move now to what Ian's raising, which is another step, if you will, a sort of systemic change that can happen within hospitals, at policy levels in state capitals or in Canberra, to start introducing, presumably, in guidelines or new metrics that actually measure people's performance. And if they're ordering too many PSA tests unnecessarily, they're in trouble. I mean, what are you talking about? Before we get responses, what are you talking about specifically, Ian?
Yeah, probably more than that. I'm talking about the funding of procedures that don't work through all of the mechanisms, not just government. More teeth for the private health industry, because the private health industry, the insurance industry, at the moment simply has to follow the government's guidelines. They don't really get much choice in that. But there's state, workers' compensation legislations and things that are currently just rewarding procedures, just paying for procedures without really demanding the results from those procedures, without looking at the evidence for them. So I think there's financial levers, but the whole system of medicine that we have, the incentives, the fact that we've turned medicine into a business that relies on turnover. It relies on more patients attending private hospitals and having things done to them. Because that's the business model, and it is a business. And I'm not sure that medicine suits the business model that well. So there's a lot of really fundamental changes that we should be looking at. And there are other medical systems elsewhere in the world. I mean, I know that solving the medical problems of the world isn't easy, but there are lots of different ways that you can structure medical systems that are different to what we have, that are possibly better.
And I think the pandemic has shown that if there is the will, rapid transformation is entirely possible. Jan or Rachelle, quick comment on Jan.
Look, I think it's interesting, Ian. I think there's far more, well, first of all, there's an MBS review process, which is going through the MBS, all 3,000 plus items. and reviewing them. And some are, I understand, not being successful and being subsidised. But there's also the issue of what the outcomes are from some of these treatments. And Raquel mentioned that, is it vertebroplasty, that procedure, that back procedure, that there's no evidence for, and there's been good randomised controlled trials that show there's no evidence for them. But the harms from those procedures are significant harms for people. And one of the biggest problems, I think, for consumers is that when you're confronted with these sorts of procedures, the benefits are emphasised and the harms are often not talked about. And I've got a number of examples of that within my own family, where that led to some very, very poor outcomes for the person involved. So it's the harms issue. And one way of addressing that, I think, systemically, is to look at patient-reported experience measures and patient-reported outcome measures, particularly for these sorts of procedures, which have been done because they've always been done, you know, the apprenticeship model, this is how we do these things. But we need some patient input into what the experience of those surgeries are and the outcomes for patients.
And so, Jane, you're talking really about medicine in its evaluation function, having much more interest in evaluating the downsides of treatment as well as the benefits. And that's historically been marginalized, let's say. But I think also perhaps even considering things like a mandatory need to inform people about serious side effects of a surgery before people consent. But they're perhaps too detailed. But some comments quickly, and then we're going to take a last comment from the participant, Rachelle.
I think one of the problems I was involved in a case of someone who became paraplegic in her 50s and had to move to a nursing home for vertebroplasty. It's tragic, and I wrote a report and they said, but it will be settled out of court, because I was thinking, great, there'll be publicity about this. These cases are settled out of court and no one ever considers whether it was necessary in the first place. And so that doesn't get into the public eye. I think we need to do a lot more regulation for vested interests. And I think the MBS review, from what I can see in my own field and from feedback I've actually had from our book, is that there are powerful lobby groups that prevent real change from happening. And things are simply not, things that don't work are simply not going to be removed without a huge battle. And it's so hard to remove things that people think it must work because it's subsidised, and now you're going to take it away from us. So I think, I'm not sure how we're going to fix that problem.
Yeah, I should point out that the MBS review is not a review of effectiveness. It's a review of simplifying billing and that kind of thing, really.
We could probably have a whole discussion about the MBS review. For those who don't know, that's a review of all of the items that are on Medicare and are publicly reimbursed in Australia. And I think you were hinting there when you talked about powerful groups, Rachelle, you were talking about, I think, professional groups. We often think of the commercial vested interests. Obviously, we know who they are, but you're talking about also the power of particular professional lobbies.
Yeah.
I think...
And those professional lobbies that also get consumer groups for those diseases to also lobby through very complicated, intricate relationships.
Yes, we're just going to take a last comment from the audience, or question or comment from the audience here. Thank you, everyone. Thank you, everyone who's been sending in questions via the Q&A. We really, really appreciate it. And greatly value your participation.
Yeah, there's an overwhelming responses and question here. We couldn't take it all. So there are a few questions about the follow-up about the patient communication, patient clinicians, clinicians, specialists. And also there is a question about the methodological fears and that's as a driver for overuse and overdiagnosis. But I think the one about the future and the solutions from Steve about, do you feel, guys, any optimism that the things are going to get better, and if so, why?
Okay, that's great, great way to end. Thank you. Thank you, Loi. Yes, so you probably heard that question. I mean, do we think things are getting better in this regard, tackling the problem of too much medicine, and how is that going to change? I mean, I'll just say this is an area I've been working in for a long time now. It must be more than 2 decades, and the awareness of this problem has dramatically exploded. I mean, when we had the Preventing Overdiagnosis Conference in Sydney in 2019, the World Health Organization was a co-sponsor. At the highest levels of the world of healthcare, there's an acknowledgement that this is a problem. I think we are now in the stage of trying to work out evidence-based solutions. So it feels to me like this problem can only improve, but obviously there are other interests still promoting it. But some comments from you guys. Ranjana, we haven't heard from you for a little while. And then the others, and we'll be moving to wind up in the next sort of 5 to 10 minutes.
Thank you for the question. I would like to say that that we should be optimistic, but given the profusion of drugs, tests, and interventions that keep coming onto the market every year, especially so in oncology, but also in other areas, I think that it will take more than Platinum. Back to Ian's point about there being carrot and stick to make this happen. The only other thing I would say is that it is essential that we democratize healthcare. Healthcare is controlled by powerful interests, including powerful doctors' lobbies. But I think that if we are in the business of providing good healthcare to people, we need to democratize medicine and make sure that the consumer, the patient, understands the elements of healthcare that for all too long have been under sort of, a shadow that only powerful and educated people need. And I think we need to remove that doctor-patient imbalance, the imbalance of power urgently.
That old paternalism. Jan, your thoughts moving forward? Optimistic?
Thanks.
Not optimistic.
I am optimistic. I think that awareness has been raised around, particularly about epidemiology because of COVID, and people are taking much more interest in preventing things like flu and COVID, and I think the younger generation is well and truly on track to change things, ironically, because of their passionate interest in climate change. I think we haven't talked about sustainability of the health system at all, and I know there's a lot of work going on in your group, Ray, on this. But as we learn more about, and the UK is well ahead of us, I have to say, on sustainability of the health system, as we learn more about what we're doing that's causing the emissions to rise, and health is responsible for a lot of emissions. I think because of the changes that are going on in our population in that younger cohort, I'm very optimistic that, and because of things like Rachelle and Ian's book, raising awareness of these issues, I think the more we can talk about these issues and talk about how we can really support our health system to focus much more on preventing illness, I feel we're on track to change.
Thank you. And you've identified this great overlap that we haven't talked about much today, but it's clear the overlap between climate change mitigation, winding back those greenhouse gases, and also winding back unnecessary care. There's a clear confluence of interests. And indeed, as you mentioned, there's work going on within Wiser Healthcare, which is, Australia is actually doing some very world-leading work in terms of the carbon footprint of healthcare. But you're right, the British NHS, the National Health Service, has really taken the bit and is running with it, trying to reduce those unnecessary emissions. Rachelle and Ian, some comments here about, some optimistic comments, if it's possible, please.
I'm glad you brought up the environment, because I think we do have an existential crisis. And so we simply must be optimistic, because otherwise we won't have a planet. And Australia, the healthcare in Australia is 7% of carbon emissions in Australia is due to healthcare. That's the whole of South Australia's carbon emissions. So I think that this is yet another piece of information that the public and the health professionals need to show that some of our healthcare, because that is, by harming the planet, they're actually harming the health of people other than their patient. So I think that is starting to be appreciated, but not nearly enough. And in our area of musculoskeletal, we did a review looking at whether anyone's even looked at carbon emissions. We found about only a few papers, and only one had tried to even measure the carbon emissions. So we're way behind. And I think that if we think about too much medicine and it's wasteful and harmful, and it's also ruining the environment and harming the health of others, I think that's such a strong case for winding back too much medicine.
Thank you, Rachelle. And before we go to Ian, I know Jan, you've got to go to another meeting.
Thank you.
So thank you so much for joining us, Jan. Jan Donovan from the Consumers Health Forum. Thanks, Jan. So Ian, please, yes, so some genuine optimism, if possible. If not, just warts and all.
I agree with you, Ray, that there's been huge changes in the time that we've been looking at it over the last few decades. And I'm naturally an optimist, and I have seen a lot of changes in my fields of surgery where things are much better than they used to be. So I'm an optimist that eventually we'll get there, that the arc of time bends towards science or whatever, that science normally wins out in the end. But we are up against, we're trying to still operate in a system that's making it very difficult. And while we're making some gains, the system that we work in is so driven towards providing more medicine that it's very hard to fight. And as Ranjana said, there's always new tests and treatments, and just as we chop the head off one, another two pop up. And so it's still going to be a very hard fight, even though I'm optimistic.
Thank you. Any final comments from Rachelle or Ranjana?
I'd only say that it's great that we are having forums like this where we can openly discuss some of the problems with medicine, notwithstanding the great advances of medicine. So I'd really thank you for organizing this, and to everybody who is attending. Thank you.
No, thanks, Ranjana. Ranjana Srivastava, Rachelle Buchbinder, and Ian Harris, thank you so much for your time. Also very important to thank Loe Albaconi from Bond University, who's been the co-pilot here. There he is again. Thank you, Loe. And also Tessa Kopp, who's been in the background from Sydney University, Dr. Tessa Kopp. And most of all, the biggest thanks of all is to Tom Dakin, the coordinator of Wiser Healthcare. We can't see him, but he's been involved in every aspect of producing this and many other things that Wiser Healthcare does. And thanks again to NHMRC for the public funding through grants for the Wiser Healthcare research collaboration. And we will see you all again sometime. Thanks so much for joining in today. Greatly appreciate your attendance.